And I think our culture is having an awakening that food matters so much to health. So when you combine, people don't want to be sick, people are tired and they want to get out of this rat race. They're looking for meaning. Physicians are burned out. They're looking for meaning. They're looking for a way to better serve their patients when the same rat race has infused medical culture and the pace at which we're forced to continue. So I think everyone's looking for an out. And then we have the science that nourishing, delicious food, the actual process of preparing food and cooking together with others, developing a healthy relationship with food so that we're using it not as a stress relief, not as a substance that alleviates something for us, but as food. We're just using it as food. That's going to help people heal.
Welcome to the Eat Your Greens with Dr. Black podcast. I'm Dr. Black. I'm a board-certified pediatrician and lifestyle medicine physician. My mission is to empower you to improve your health and the health of your family by giving you the tools to take what science has to say about a healthy diet and lifestyle and apply it directly to your day-to-day life in actionable and sustainable ways. I'm beyond excited to share this episode with you. I had the great fortune to be able to interview Dr. Jaclyn Albin. She's a leader in the culinary medicine space, and let me tell you, I'm in awe of her and the work that she and her team are doing. She has a very impressive resume, or as we say in healthcare, curriculum vitae. Dr. Albin is an associate professor of internal medicine, pediatrics, and public health in the UT Southwestern School of Medicine. She's board certified in lifestyle medicine and med peds. So that's a combination of internal medicine, so adult care, and pediatrics. And she's a certified culinary medicine specialist. She's the associate program director for the combined internal medicine and pediatric residency program. And she founded and directs UT Southwestern's culinary medicine program. She also serves as the inaugural medical director of Food as Medicine Innovation in the Center for Innovation at Parkland Health. If that's not impressive enough, Dr. Albin also serves on the National American College of Culinary Medicine Advisory Board, and she's an organization member of the International Teaching Kitchen Collaborative. She is passionate about, quote, disruptive innovation within healthcare to promote multi-sector collaboration and drive positive change at a population health level. How impressive is that? I don't know about you, but like I said earlier, I am absolutely in awe of Dr. Albin and everything that she's accomplishing. In our interview, she and I talked about the unique opportunities that culinary medicine offers for helping individuals gain the knowledge and skills needed to improve their health. And I got to pick her brain about how one goes about developing a culinary medicine program. I know you're going to love hearing what Dr. Albin had to say just as much as I did.
Thank you so much. Glad to be here today.
I'm so interested in hearing about your program, and I know my listeners will be as well. The individuals that listen to my podcast tend to be people who want to take control of their health, change some habits, especially around nutrition. And culinary medicine offers a unique opportunity for people to learn how to do that. So I'm personally interested because it's one of my aspirations to start a culinary medicine clinic within the corridor primary care pediatric practice. So I have a little bit of a selfish interest in this conversation, but I know that my listeners will also find it fascinating and may want to know how they can take advantage of a program like yours. So why don't you just start by sharing a little bit about your journey? How did you find yourself in the lifestyle medicine and culinary medicine space?
Absolutely. Well, I think most of us who've been doing this work for a while have a very personal story, because when you end up doing something that's off the beaten path of medicine, it's usually because of a need in your own family or a passion that you had. And that caused you to pursue something that was really different than what everyone around you was doing. And so I was traditionally trained in medicine and actually joined the academic faculty here at UT Southwestern over 10 years ago. And I've been part of building residency program and doing all the normal things, if you will. But on the side, I've always been passionate about nutrition since childhood, more about food than nutrition. And I think that's an important distinction that we'll come to, is that taking this nebulous concept of nutrition and making it about the beautiful, delicious food that's on our plate in a way that makes sense to us and that we can get excited about. And so my grandparents were all farmers, and I remember growing up being on tractors and experiencing from my grandfather in particular how food is grown and seeing it fresh and growing from a seed to something that I can pick and eat. And so that stays with you as a child when you understand where your food comes from. So I think that was a gift that I had. And then when I chose to pursue medicine, I had no idea that food would become a big part of it for me. And in the training process, I was roughly early residency when my husband got a diagnosis of celiac disease, which was about 15 years ago at a time when nobody really knew what it meant to be gluten-free. It's easier to do that now, and there's a lot more available, whether you're at a restaurant or a grocery store, but then we really didn't have much information available to people. And so he comes home from his physician appointment where he gets the diagnosis confirmed and says to me, "I hope you know what to do." And I had a panic moment because I'm training to be an internist and a pediatrician, and I have no idea. And I felt kind of like a failure to my own family and to my patients that this was this gap that I hadn't previously recognized. So that was the beginning for me, was saying, well, what do I know how to do? I know how to read the literature and ask questions and learn new things. And so I started doing that about 15 years ago.
We have that in common. I have a family member with celiac as well and had to learn a lot about special diets. And then our daughter, who I talk about a lot, who has epilepsy, was on the ketogenic diet for epilepsy for a number of years, which is super strict, very low carb. So they aligned a little bit because, many of the grains that have gluten that he couldn't have, she also couldn't have because of the high carbohydrate content. And at the time, my older daughter and I were both vegetarian. We were lacto-ovo vegetarian. And I remember thinking, nobody better come up lactose intolerant, because right now the only thing everyone in the family can eat is cheese.
Cheese and eggs, right?
Yeah.
Well,
exactly.
I think the familiarity with the ketogenic diet for epilepsy is often the one thing medical students know about nutrition. And you ask them, okay, what's this for in medicine? Because we actually have science for it. But they don't know that dietary pattern affects literally everything else as well. And that we make it too complicated for the average person who doesn't have a special condition. Most of us should be eating quite similar foods, but we don't understand how to apply that because there's so much misinformation out there.
I agree. And culinary medicine, I think, is a great opportunity for people to have a hands-on educational experience about what a healthy diet looks like. So for my listeners who are unfamiliar with the term, how would you define culinary medicine? Like, what distinguishes it from nutrition, like if they met with a registered dietitian, or what distinguishes it from just our general medical practice and how we coach patients on their health?
Sure. So I see culinary medicine as a bridge builder. And in medicine, we tend to get in silos where we think about one domain. And fundamentally, culinary medicine bridges culinary arts, culinary tradition, which includes culture and foods that are really important to us as families, as communities. And it bridges that to nutrition science, which says, what do we actually know and not know about how food affects health, both as a protective to prevent disease and to help manage disease. And then that bridges to medicine to say, how can this be part of a treatment plan? Instead of seeing it as something completely separate, let's include it. So it's the bridge building of those areas, nutrition, medicine, and food and culinary skills. And it says this should and can be part of traditional medical care. And so it's a bit of a reframing of something that maybe people historically haven't considered part of science or medical care, but they've missed this beautiful opportunity for us to treat and care for patients differently and more holistically.
And that just speaks to me on such a personal level in terms of both my goals for taking care of my patients and helping them with their health. And then again, going back to my personal experience with my family members and having to come up with meals that met everybody's needs in an accessible manner. Tell me a little bit about what your practice looks like. What does a typical patient experience as they go through your program?
Absolutely. So we started culinary medicine, and I want to say that it fits everywhere because everybody eats. So you find a group of people, we can teach them culinary medicine. And so we started with medical students because the vision was, how do I train the next generation to be able to talk about food with their patients thoughtfully, non-judgmentally, and usefully? Because most people think back to conversations they've had with their doctor about food and it hasn't been particularly helpful. I'm sorry. We both apologize on behalf of doctors for that. And it's our lack of training. So how do we set them up for success? So we did that initially. And it was the students who said, okay, we're ready to go talk to patients about this now. Take us out there to the community. And it's often a medical student who's not even clinically seen patients yet. And they wanted to get to the food pantries and community centers to help support their fellow community members who were struggling with this. So that was what birthed our program initially, was because of medical student interest, we started building programs typically in areas where people often had food insecurity. And so it's an added layer of challenge for them, was having consistent access to nourishing food. So that's the framework of our program, is this is for everyone, and it matters most for people who have more struggles. And so then over time, it became clear to me that there could be a sustainable program if we made this patient care, because it is just as relevant and maybe even more impactful in patient care than what I was already doing as an internist and as a pediatrician, where I often felt unsatisfied by how much time I had available to talk about these things. And I could see my patients' eyes linking with me. Yes, tell me more. How do I do this? So we do have some work to do on the what we should eat, but most people, to your point, really want help with the how. And so that's what we do in culinary medicine. So now we have an entire clinic dedicated to this. And while myself and I have a dietitian who is trained as a chef, so she's called a culinary dietitian because it is a unique skill set. So dietitian nutritionists are nutrition experts. They are not always culinary experts, and often not, in fact. And so, fortunately, there's this whole new generation that's passionate about doing both and saying, how can we even talk about food and nutrition without including the kitchen? And so this is a real gift that I have, this person who's both. And so together, we see patients both one-on-one in a traditional clinic, where we talk about their food relationship and their history of what changes they've made. What have they tried? What do they like? Because we can't really create a plan for someone without understanding the history of food. And a food history isn't something we're necessarily teaching in medical school. So we've had to learn how to do that as well. So after people have been seen one-on-one, or if they're already one of my partner's patients in our primary care group, they can come to the group culinary medicine classes, which is not a one-time experience. And I want to emphasize that, because if you're trying to learn something new, you rarely get it down after one time. So we have a 6-class series, and most of our patients attend at least 4 of the 6 classes. And we think that's about the sweet spot of feeling more confident that you can do this in your own kitchen. And when they come into a class, it's a little bit like a regular medical appointment, except that it occurs in a community kitchen. So we actually rent community kitchens, and my staff team comes over just to take vital signs and check people in. And then they will be seated at a table where they have a handout and an exercise or a discussion that they're going to begin with the group that's seated at their table. We have about 16 patients that come to a class, and then we do a little bit of a demo to start. So my dietitian might come out and say, you know what? Part of cooking, part of the how is cutting things efficiently so that you spend less time chopping vegetables. So she'll teach them the fastest way to cut an onion, the fastest way to cut a bell pepper. How do we do this safely and efficiently? And another time she might teach them how to prepare a food that's less common, or how to add flavor with spices. So there's lots of different culinary skills that she's going to give them over time. After that is the best part, which is when all of the patients go into the kitchen and they're assigned to a team. And we have usually 4 teams, each making different recipes. And all of the food is already there for them, that we've gone to the grocery store for them. We got it set out for them. And we have a team of volunteers, usually students and other community members, that will help set everything up in advance. Then the patients make their dish. And throughout the whole process, they have access to our dietitian who's helping them understand, okay, why did we choose these ingredients? If you don't like this, how could you substitute that? So it's helping someone see not that specific recipe as the be-all, end-all, but hey, what would it look like if I tailored this to my family's preferences or my family's food sensitivities or allergies? And then after that, everyone presents what they made to the group. They put a little sample plate together and they say, hey, this is what it was like to make this. When we tasted it, we thought it needed more of XYZ and we added something. It was just the process of preparing it. And that normalizes. Everyone runs into bumps in the kitchen, and then you have to problem solve and you have to figure out what you're going to do to make something delicious. It teaches people the skills to not give up on something that maybe doesn't go the right way the first time. And then after everyone presents their food, we all get a plate and everyone tries what everyone else has made. And so that's the fun part. Everyone sits down with their plate and celebrates what they've made and shared with their new friends. And we end the time usually with a little bit of discussion and goal setting, because part of what we hope to do is to teach people to make realistic goals. Because if you go home today and say, I'm going to change my entire diet, how is that going to go for you? Not very well. So how do we help people set, I'm going to purchase apples, keep them on my counter so that I see them and try to eat one alongside my breakfast every day to ensure I'm getting more servings of fruit. That's an example of a goal that's going to be a little more realistic or practical. And that may not be what the person next to them wants to make as their goal. So everyone's going to have an individualized approach. And so that's culinary medicine. And by the end of a 6-class series, my patients are exchanging phone numbers, scheduling to meet up and cook together, becoming exercise buddies, because we crave community. We crave doing this with other people. And that's part of the magic, is you're learning that you're not alone.
That is amazing. And all of the components that I've learned about in my lifestyle medicine education are incorporated right there. The goal setting, the educational piece, and the importance of connection, of community, all wrapped up in what is ostensibly a medical visit, but unlike what anybody really thinks of ever as a medical visit. Who chooses the menu options? Do the patients make suggestions? Do you have a list of things that they choose from? How do you come up with the dishes that the various groups will be making?
Yeah, great question. So I will say that because culinary medicine has been growing so rapidly, there's actually quite a lot of recipes that have been created for this model nationally. And we do use a national curriculum that is by the American College of Culinary Medicine. And we've adapted that curriculum to our community. So we have a very diverse community in the Dallas-Fort Worth area. And so at any given class, we might have 5, 6, 7 different cultural backgrounds in a group of 16. And so we always tell people, we're going to make some foods that resonate with you and that are your flavor profile. And then we're going to make foods that aren't, because we're trying to bring foods that represent lots of different cultural backgrounds into the experience. So when you try something that maybe isn't what you would have chosen or made, think about, could you adapt that to your preferences? Or maybe you find that you like something new that you wouldn't have tried. So that's one key piece, is an open mind is important. It is impossible to satisfy everybody's preferences at every single dish. And we also want them to recognize it's not this recipe. This is not a Bible. This is an example of how you can bring things together to create a nourishing dish. You can adapt this. It's an adaptable model. So traditionally speaking, we will start with a set of recipes based on the expected demographics of the patient population that we have. And then we run stakeholder classes. And so in our case, we're actually running these classes in church kitchens in the southern part of Dallas, in a community that's primarily Black. And so as white women who are running the class, we actually invite the leaders of the churches to come to stakeholder classes and share their honest feedback about the experience, the class, what recipes resonate with them, what do they like and not like. And then we adapt our recipes based on the local feedback. And even within a class cohort, we will shift our recipes based on what we've been learning about the group who's in that class. So we may have two cohorts at two different churches that we use running at the same time frame, and they don't have exactly the same recipes because we've tailored it to what we can tell everyone is enjoying, and or what their kitchen equipment is like. We also keep it simple, and you can buy everything at Walmart. This is not like a Whole Foods experience. We are focused on, you can buy nourishing, healthy, affordable food for culinary medicine. So that's kind of the overall philosophy, but we're reflecting traditional Southern cuisine, Latin American cuisine, Indian and South Asian cuisine, Mediterranean cuisine. It's got kind of a little bit of everything.
How many community kitchen sites do you currently operate out of?
So we have technically 4. I will say our main campus kitchen is actually only for learners. So we don't bring our patients there. That kitchen's from 1960s, and we are not able to bring patients into this particular building. So that is just for our residents and our students. Our community kitchens serve 2 purposes. One is to get the kitchen close to where the people live, because we don't want this experience to be stressful where you have to drive an hour and then you're in the hospital parking garage and it's just a big effort to get there. We want to make it easier is the whole point. So we do have one community kitchen in Fort Worth, which is affiliated with a nonprofit cancer survivorship center. That's the nonprofit arm of my university's cancer center. And so it's just a community room that we turn into a pop-up teaching kitchen. And then we have 2 churches where we are actually using their kitchens. And these were extra kitchens. They are large churches that have multiple kitchens. And we sort of set it up on purpose to use a space that wasn't really being used. So we brought in tables, portable burner units, all of the equipment needed. And we have over time figured out exactly what do you need to turn any space into a pop-up teaching kitchen. You pretty much just need electrical and ideally a 3-compartment sink for dishwashing. And then everything else we can bring in as a pop-up. And then our third site, those are both in South Dallas. And then our third South Dallas site is actually a food pantry market that is one of our largest food redistributors, and they are building a co-located pantry in the, it's a mall actually that's been repurposed for social impact, and both our university and Parkland clinics are in this mall. And so the food pantry is moving there too, because co-locating access to food with where you get your medical care makes it a lot easier for people to get it done. You know, can you imagine anytime you can get 2 errands in one spot, you know, it's a win for families who are busy. And so we have a kitchen space in that almost completed build out where we'll be offering classes as well. So it's kind of endless. Schools, YMCAs, faith-based organizations, anywhere there is a kitchen-like space and then a space where people can sit down and eat, you can make this work.
What kind of equipment do you have for the pop-up kitchens? Like, what do you bring?
So we don't bring anything, and that we did that for many years, where it filled our trunks of our car. But we are now in a spot where when we make arrangements with kitchens, we ask them to give us a storage closet. So we're able to keep everything on site except for the food ingredients. So in the ideal class, we will have 4 stainless steel tables, and then each one of those tables will have their own portable burner unit that we're going to plug in so it functions like a stovetop. And then we'll have some cutting boards, knives, bowls, other mixing utensils. Usually we try to have one oven in that and one microwave because some recipes are going to need those 2 things in the kitchen spaces that we work with. If they don't have that, we try to get funding. I usually am applying for small local grants and try to get things donated. And then all of this equipment lives at the location where we run the classes. So when we go there, we're just unlocking the storage closet, setting it up, and setting out the groceries so we're not carting stuff around.
Talk to me a little bit about funding. You mentioned some small individual grants. Walk me through how you got your program off the ground.
Okay, well, so 2 things I'll say is that anyone doing new things knows there's a lot of your own blood, sweat, and tears that has to go into it. And that's just part of doing new things. And so we all recommend finding a friend or 2, whether it's another community member or it's another clinician that you're working with. I was really fortunate to have my culinary dietitian partner from the beginning. And so we are constantly creatively figuring out how to keep things going. We were fortunate that Moncrief Cancer Institute, who is the cancer nonprofit, did have some philanthropic funding dedicated to offering culinary medicine to cancer survivors. So my dietitian partner actually is an employee of that institute, and her job is to deliver culinary medicine to cancer survivors. I ended up donating most of my time initially, which is part of why I think it's so impactful to do this in a patient care setting, because we're able to make it part of our jobs as clinicians when we can bring it directly to our patients through health insurance billing. But starting out a program, I'll be honest, I was buying a lot of things, and going to the grocery store on the Albin family budget, and that limited growth. How are we going to be able to expand this when I don't have the resources to expand it? Over time, we have, in addition to the wonderful philanthropic Moncrief family, we've been able to build out what we do with two other things that are independent of patient billing. One is our residency programs and our fellowship programs recognize the value of doing this for their trainees. So you take a group of family medicine residents, for example, the UT Southwestern Family Medicine Clinic said, hey, we're training doctors who they're going to see children, adults, pregnant women. Who else but they could it matter more to have an understanding about the role of food? So they actually pay for their residents to come and train with us, and their residents get a lot of training. And so it's beautiful to see these residents graduating and making this part of their careers. They're going to their clinics with an extra skill set and saying, hey, I can bring this to my new clinical practice. So I think we're going to see more and more of that. We work with our gastroenterology fellows. We're soon to work with cardiology. We work with endocrinology. So what if everyone's doctor had a common language in the future to talk about this, and you could get really consistent advice that was evidence-based and practical at the same time? That's what my hope is for medical education. But so that's medical education-based funding. In our patient program, we actually got a grant that was through a community arm of a National Institutes of Health grant, and said, hey, how do we transform community programs that reduce risk for chronic disease and help support health in diverse communities? And I applied for that grant, hoping to aid in the startup costs of starting all of these sites. And so that is what paid for our initial startup costs for the supplies. Now we are billing health insurance because we're addressing diabetes and high blood pressure and obesity and any type of gastrointestinal disorder or disturbance that someone has, food allergies and sensitivities, on and on, fatty liver disease. These things are allowing us to bill because we're directly treating those conditions with what we're teaching. And that then covers the cost of our time.
And I know you're med peds, but your program really is an adult medicine program. Having said that, those are a lot of the things I'm seeing in the pediatric population already. Many of them haven't actually developed type 2 diabetes, although a few of them have, but I am seeing trends towards pre-diabetes. Definitely the liver inflammation associated with the fat deposition into the liver, the elevated lipids. So it's applicable to the pediatric population, even though they haven't necessarily gone on to develop the full manifestation of those disorders. So it aligns so well with what I'm trying to do in my practice.
Well, and the timing of doing this in childhood is actually better because the old adage, an ounce of prevention is worth a pound of cure, is so true here. Because if you want to prevent diabetes progression, we have good science for this. Lifestyle works to prevent diabetes progression. Almost all diabetes is preventable. And I feel as though so many of my patients have never been told that. You don't have to have diabetes just because it's your family history. How do we set you up for success and give you the tools to prevent progression? We have not been doing that well. So doing it early means you have less radical change necessary to be able to prevent progression. Whereas I'm working with people who are maybe in their 50s or 60s and they've had decades of disease. We're going to help manage that disease, but it's going to be a lot harder to see successful reversal and to actually take people off medications. I love taking people off medications. That's one of my favorite things as an internist. But as a pediatrician, I'd really love to say we're never going to get to the medication. We're going to be able to avoid it. If we need to, then we will. We're going to do both. And I'm not opposed to medication, but most of my patients don't want it. They want to find a way to avoid medication, especially for children. So I love that. We actually have done pediatric classes. We wrote a pediatric curriculum. And I have that open access. It's published in the literature. Anyone who wants it can ask us for it. We also have an additional pediatric curriculum available to us through the curriculum we license from the American College of Culinary Medicine. And they have both a family-based curricula and a pediatric-specific one. So there's a lot out there.
It's such a critical need right now on the pediatric side, given the current state of our healthcare system and the cost of healthcare. It's part of the reason I'm so passionate about developing this at the pediatric level. I think moving forward over the next few decades, our healthcare system is really going to be in crisis, even more than it is now, with the rising rates of obesity, liver disease, heart disease, dementia, all of these things. So addressing it at the prevention stage will save millions of dollars.
I absolutely agree. And I think the hard part, what we're facing right now, the challenge, and it's not just the money, of course. Nobody wants the suffering either. And so we're preventing disease and all of the associated suffering in addition to the cost. And increasingly, economists are measuring the lost productivity to society. And even things like military readiness are at risk in our country because of chronic disease in childhood that is with people for the rest of their lives typically. So I think the hard part is when you're talking to, I call them the bean counters, but when you're talking to business folks, their return on investment is a very quick turnaround almost always. They want an intervention to prove what it saves or what it earns quickly. So medicine deal for what we gave you. This is a perfect example of something that adds value, but am I going to be able to measure change quickly? Lifestyle behavior change takes months and years, not days. And so if we're helping support sustainable change, which is the goal, I don't want somebody to go on a radical shift and then go back to their previous lifestyle in 6 months because it was too hard. And so that means slow, steady wins the race. And I'm not going to see your A1C radically improve most of the time over a short period. So how are we able to convince people that a little bit of investment now, we're saving for retirement, is going to pay off big later? Not everyone gets that yet.
It's unfortunate and absolutely one of the challenges that I'm up against. Can you share a success story from a family? I mean, you were talking about it takes time to see improvements with the program, but have you had any stories, any success stories that come to mind with a family or a patient?
There's one that immediately comes to me and it makes me smile. She has actually agreed to have her story shared and participated in a video that we did of our very first launch of this. And so I'm happy to share that link. It's on Vimeo and anyone can watch it. But the funniest thing is she came to me on the very last day of my internal medicine clinic. And I was apologetic in a way that I explained to her, I'm actually leaving, so I'm not going to be your internist, but I'll be happy to get you going today. And here's what I'm going to do next. She started crying in the room and said, I think I was supposed to meet you because what you're going to do is exactly what I need. And then she described that she's in her 60s and she's now caring for a young child that she now has custody of from a relative. And she felt so terrible all the time. She said, I'm sluggish. Everything hurts. I don't have the energy for this child who deserves more than that from me. And so that is one of the key take homes from this work is you have to get to your patients' why. We as individuals, we have to have a why that we want to change. And it's maybe more than one thing, but understanding a motivator for ourselves and those around us is the core driver of why we're willing to make change. Change is hard. So she comes to class and every single class, she was just enamored with what she was learning, trying new things. People who come to culinary medicine are able to try foods that they might not have bought the ingredients for on their own, but now they learned they liked something in a low risk way. And so that was one of the things that she took away was I'm trying all these things I would have never tried, but now I want them in my diet. And keeping an open mind that there's a lot to learn about foods that maybe you've never been exposed to. And then at the end of the class, she was sharing with the whole group, I came here for my diabetes, but I didn't realize I wasn't going to hurt all the time anymore because I started putting so many fruits and vegetables into my diet. My inflammation went down. So my joints don't hurt all the time. I have more energy. I lost weight. And so all of these repercussions came because she came passionate about being a better mom for her new son. And it was just such a beautiful story. And I love how it all happened where she wasn't even supposed to see me, but it was meant to be. And we were able to join forces. And now she still follows up in our one-on-one clinic. So I'm able to see the progression of her life story.
That's beautiful.
I want my patients to have a healthy relationship with food. And so many people come with a very dysfunctional, shameful, guilt-ridden, messy relationship with food. And that's a tough place to be in. And we don't have to have that in our lives. And so that's one of our biggest goals is helping people reframe their relationship with food.
Where do you see the field of culinary medicine heading in the next, say, 5 to 10 years?
Well, I think we're at a tipping point for a couple of reasons. One is because it hits so many needs. People want to eat delicious, nourishing food. We have to rebrand that healthy eating is not a punishment. It is not gross. It is not sad. It's beautiful. It's fun. It's creative. Preparing food in and of itself can be a mindfulness stress reduction strategy. I actually love listening to music or a podcast while I'm chopping vegetables and sort of getting in the zone where nothing is interrupting what I want to be thinking about. Engaging children in the kitchen, in the cooking process, is a way to have family time. And I really dislike our frantic, hurried paces that we have accepted as normal. In my own family, we are trying to slow down a little bit to be more present with one another. And one way we do that is actually being in the kitchen together. And so we assign one of the nights each week my kids take as sous chef. So they get to choose what is the recipe, and they make the grocery list. They look in the pantry. What do we already have? And I'm teaching them the skills of don't go buy the things you already have and, waste money. What do you already have? And then they're going to be part of the experience. Kids can do that as young as 4 or 5 and in a developmentally appropriate way where they're helping. When they're 10, 11, 12, they're actually helpful because my youngest, who's 10, puts on a steel glove on one hand and I give her a chef's knife. She is chopping fruits and vegetables because we've taught her how to do that safely. And so, it's a skill set. And then it's some of our favorite memories. It's not just we're making cookies at Christmas. We do that too, right? But my daughter will know how to prepare food that she likes for the rest of her life. My son is going to go to college and possibly be one of the only young men who knows how to make an actual meal. And so I think it's a life skill you can't take away. So we have to value that. And I think our culture is having an awakening that food matters so much to health. So when you combine people don't want to be sick, people are tired and they want to get out of this rat race. They're looking for meaning. Physicians are burned out. They're looking for meaning. They're looking for a way to better serve their patients when the same rat race has infused medical culture and the pace at which we're forced to continue. So I think everyone's looking for an out. And then we have the science that nourishing, delicious food, the actual process of preparing food and cooking together with others, developing a healthy relationship with food so that we're using it not as a stress relief, not as a substance that alleviates something for us, but as food. We're just using it as food. That's going to help people heal. So I think there's no possibility that this isn't going to grow. I think it's where it's going to grow the most is yet to be determined. We have huge amount of funding available to do research in the best ways that we can deliver food as medicine, which is an umbrella term for using food in healthcare, includes culinary medicine. How is that going to look as we grow? I hope it means people like you are going to be infusing this into their practices everywhere, and that people who aren't doing it are going to feel like they're missing something, because we are missing something.
It's so rewarding. You just summed up beautifully my entire motivation for doing all of this. That was a beautiful summary. Can you share some actionable tips that families can use to start making changes to their diet now?
Decide one small thing as a family that you want to work on. And I'll have some families who say, you know what, we're eating too much meat. We want to reduce our meat. Does that mean you have to immediately shift to a vegetarian food? No. How about you take a can of beans and you add that to something that might be meat-based, like a spaghetti sauce or taco filling or a stew. You add beans, you lower the meat gradually. So think about how you could take a process towards a goal that you have in your diet. If you are not eating enough fruits and vegetables, that we actually have benefit up to 8 or 9 servings a day, which no one is getting. Actually, the USDA's recommendations, the dietary guidelines for Americans, only 1 in 10 Americans are getting the 5 to 6 servings a day that are recommended. So we all have room for improvement. Start keeping track of colors. How many colors did I get this week? How can I expand my colors? And I actually love giving kids a rainbow coloring sheet and making them come up with something that they like in every color category and something that they're willing to try. So maybe you design a recipe this week on the color food that a child recommends. And you just go to ChatGPT and say, hey, give me some recipe ideas using purple cabbage, and boom, you'll get 3 recipes. I actually do this all the time using tools like AI to help us with the cognitive load. So find a way to experiment, but make it the fun part yours, the work part using technology, and it's going to make it more accessible for all of us to add foods to our diet.
Dr. Albin, I really appreciate you taking the time today to join me on the Eat Your Greens podcast. I know my listeners are really going to be interested and benefit from everything you've had to say. I know I'm benefiting directly from everything you've had to say. We were supposed to be doing this in person, but our whole 2 weeks of winter for Texas arrived this week. And so with the weather interfered with it, but I'm looking forward to coming up to Dallas and seeing firsthand how one of your teaching kitchen sessions runs. But thank you very much for your time today and sharing all of your expertise and knowledge.
It's been my pleasure. Look forward to eating with you soon.
I don't know about you, but I came away from my conversation with Dr. Albin feeling energized and motivated. I feel like for me, this really highlighted the need to go beyond traditional office-based nutrition counseling and meet patients where they are to actually help them gain those skills needed to put that advice into use. I'm excited about how lifestyle medicine and culinary medicine has the potential to facilitate self-efficacy and even manage chronic disease, lower healthcare costs, and also to foster connection and community in the participants. On my website, eatgreenswithdrblack.com, if you look at the show notes, I have put links to the patient story video that Dr. Albin mentioned. I also included a link to culinarymedicine.org if you're looking for a culinary medicine program near you. So please head on over to the website, check out all of that useful information. While you're there, go ahead and subscribe so you never miss an episode. You'll get an email every time I release a new episode. And while you're at it, on your app where you're listening to your podcast, please do me a favor, rate it, and if you have a few extra minutes, just leave a review. I really appreciate it. Thanks for listening, and don't forget to eat your greens. Please be aware that this podcast provides general health information about nutrition and feeding of infants and children and is meant for educational purposes only. It's not intended to replace the important relationship between a parent, child, and pediatrician. If you have concerns about your child's nutrition, health, or growth, please consult your doctor.